how are challenging courses like anatomy and practicals handled? How are the students set up for success? So that's partially for Dr. Welke to answer, but it's also partially for you as students to answer.
We have 2 courses. So we have 5 semesters, and there's 2 courses in each semester: Foundations of Medicine and Patient-Centered Care. And even between those 2 courses, they're aligned. So I think the best example is semester 2. So Foundations of Medicine course in semester 2 has 3 units: cardiovascular, respiratory, and renal. So it's not discipline-based, it's organ system-based. And so within cardiovascular, and you guys can help me out better with how your experience was, but you might start off with cardiovascular physiology, but you're going to have a physiologist in there and a clinician and maybe a pharmacologist, and they're weaving it together. Like, why should you care about this? Why is this applicable to hypertension and other disease? So you're going to learn the anatomy, the physiology, the pharmacology, the biochemistry, and the clinical all at once rolled in to a patient or patient case. So we say patient to DNA. And then within your patient-centered care course, that after, let's say you have that in the afternoon, you'll go and do clinical skills like heart sounds or other diagnostic skills within the clinical suite, which we sit in now.
Coming from a different institution where they front-loaded all of our anatomy within that first semester, that was very hard because you're learning, say biochem, and then at 8 a.m. and then 10 o'clock, you're learning about, the large intestine. And you're kind of like, your mind is in 2 different places. And with our curriculum, the way it's set up, you're learning your, say, GI anatomy while you're in GI. So I'm not worrying about the heart muscles and the papillary muscles and the valves of cardio, while doing biochem. I'm doing it while I'm doing that unit. So, I shouldn't be saying this if I'm an anatomist, but, I don't like anatomy. And I think with our curriculum being so focused on not only students, but also on patient-centered care, which is a big part, one of the courses, even our anatomy is really on what we need to know to help the patient. It's not, we're not going to ask you these fine, small details, that won't be applicable to your practice in the future. It's what is clinically relevant and how does it all tie in to that patient script. So much as I don't like anatomy, I've actually enjoyed anatomy, and so it's been a lot easier to just digest information the way that's presented.
If I can just add, apologies, but this is I was just having this conversation with Dr. Coleman, who's one of our anatomists. He's wonderful, and you can imagine, like, in the human body, like how many, we just call them attachment sites now. You might know origin, insertion, and the old time when I was an anatomist, you have to memorize like hundreds of like origins and insertions, right? Here we do 20 or 25, right? And so, and they're the most at the end. And why do we do those? Because they're clinically relevant and they're applicable to what you're going to see if you're an orthopedist or in a sprain or strain or whatever. But that gives you an idea, is that we're whittled it down to what do you really need to focus on and know to be in clinical practice, instead of all of these tiny granular details, that just cause stress and anxiety and the overwhelmingness, because you're not coming to WAUSM to get a PhD in biochemistry. You're not coming here to get a PhD in behavioral medicine. So we're really trying to say what is really relevant and integrate it between. When you're in Foundations of Medicine, there's like that specialist who is the physiologist, biochemist, whoever it is, but then you have a clinician. Chances are that same clinician is the person who's running your PCC. So you get to tie it in, and it's like, okay, if you can't read the PowerPoint slide and you don't understand how the heart sounds work because they show you it, you can actually go in and listen to Harvey. And if you're a hands-on person like me, you can understand it better that way. We have a professor here who basically says our job as med students is to know nothing. Not that we're not learning, but if we're asked a question, it's okay to say, I don't know, I don't get it, and they will walk you through it. And so I like the fact that in Foundations, that same clinician who is actually an MD or a DO, whatever the case may be, they're in clinic with you for PCC and going over like physical exams, listening to heart sounds, what to look out for. And as Dr. Walke said, we're not learning an entire textbook. We're learning the high yield stuff that's going to help us when we're actually on the